very informative and educational, very interesting evenings. And this evening we are hosted by our Limpopo branch, who have come up with the topic that we will be presenting today, as well as the speakers. So we'd like to thank the Limpopo branch and the entire committee for all the hard work that they've put into this. Please bear in mind that we will be live streaming on YouTube. The link will be shared on our Facebook platform if you're unable to join on our Zoom. The link will be shared on Facebook and it will direct you to YouTube. We are expecting about 640 participants in this webinar. We're sitting at 250 right now, so we are well on our way to our capacity. I'd like to just inform everybody that our new platform at SADA is now active. We are live on our new platform. So all your CPD certificates will be uploaded onto the platform. It is a process that is taking place, so please just bear with us a little bit, but your CPD certificates will be uploaded on our new platform. So without wasting any time, I'd like to hand over to Dr. Khan Patel, who is the president of the Limpopo branch, to introduce our speaker for tonight. Dr. Khan, over to you.
Thank you, Interviewing. Thank you so much. On behalf of SADA Limpopo branch, we'd like to thank and welcome everyone to tonight's webinar. Dr. Bowles needs no introduction to dentistry in South Africa. And I'm going to read a small abridged CV of this esteemed clinician. Okay. Dr. Mark Bowles is the owner and clinical director of Enamel Restorative and Cosmetic Dentistry, a private practice in Cape Town, South Africa. His practice is limited to aesthetic and complex restorative dentistry. Mark has been a fellow of the International Congress of Oral Implantologists since 1997 and a speaker for ITI. In 2010, he founded the South African Academy of Aesthetic Dentistry, for which he is now the past president. He was the Congress president for the World International Federation of Aesthetic Dentistry, held in Cape Town in 2015. In 2018, he founded the Digital Dentistry Society of South Africa, for which he is the president. Mark has pioneered the development of digital smile design in South Africa. This concept allows dentists to develop a smile which fits the individual patient's aesthetic and functional needs whilst providing minimally invasive dentistry. Mark is a DSD World Master and is also a DSD instructor. Mark is a KOL of numerous influential dental companies and has lectured extensively in Southern Africa and internationally on all aspects of aesthetic and complex restorative dentistry. That's a very abridged version of Dr. Mark Bowles' CV. And we're all looking forward to a very informative evening. Thank you so much.
Thank you so much for that. I'm good to go. We're good, huh? So, yeah, that's really kind, those words. I have to say a few things before I start. Firstly, as humble as it might sound, I'm not, when I say I'm just a GP, I'm a GP dentist. You know, I'm not a specialist. And what we're going to see tonight is, in all honesty, I think, in my opinion, achievable by all of the dentists who are watching. You know, I think it's about detail. It's about understanding our goals and what we're trying to do. But really, I think that all of what we're going to see is possible for all of us. So, you know, it's an honor and a privilege. Thank you so much for the Limpopo branch and for SADA as a whole for everything they've done for us, for my long career. And obviously this year has been a really important year that's really, you know, touched dentistry in probably the wrong way that we would like it to have been touched. But I think SADA has been the rock, and thank you to Casey, the team. I don't want to single out anyone for the support, the guidance, yeah, and it's everything that they've been there for dentistry. So yeah, it's my privilege to be here. As I say, also an honor to share my experience. So thank you so much. Can I go ahead, or we're good?
Yes, Dr. Bowles, you can go ahead.
Okay, thank you. So I'm just going to do that. Right. I've just lost my video. Okay, can I just get my video, the only one? That seems like that yours is the only one there, but anyway, not to worry about that. I don't need to see myself. So my topic tonight is about how materials have simplified aesthetic dentistry. And I'm going to just hide that completely. And so really it's about materials, but it's more than that. It's about really an overview of where I believe aesthetic dentistry is in 2020. But the emphasis is really, and because the reality is without materials, there almost is no dentistry. And it's really how the materials have changed to allow us to become better dentists, not just from an aesthetic point of view, but dentists from a restorative point of view. So as I say, it's an overview, and my video isn't going. So I'm just going to stop sharing my screen once. 1 second. That's exactly what happened last time. Let me go back in. Right. And so I thought about really a theme, something that's going to be at the forefront of what we're going to talk about tonight. And yes, it's restorative dentistry. Yes, it's aesthetic dentistry, and more importantly, materials. But really, you know, what I want you to go away with is the idea that when we treat our patients, and certainly aesthetic cases, let's make it count. You know, let's really do it in a way that there is not just 80%, 90%, but every case that we do is the best case for that patient. And I think this is super important. And, you know, more and more, I think, obviously, social media is what it is, and it's there to stay. And it's great because I get the opportunity to see cases from all over South Africa, and in fact, all over the world, which are posted on social media. And in fact, I as you probably know, I post cases myself. But the danger, I suppose, about social media is that really, in my opinion, you know, if we're prepared to put something out there for the whole world to see, it has to be perfect. And so, you know, every case that I do, not just a special case for that person or for a special patient, but every case I do, I want to make it count. And so, you know, if I'm going to put it out there for everyone to see, yeah, it has to be absolutely perfect. And so that's hopefully what we're going to be focusing on over the course of the next hour. So two of the most important things, or two things that I really focus on when it comes to these aesthetic cases, cosmetic cases, I prefer the word aesthetic, I have to be honest, is form and function, and they go hand in hand. That without form, there is no function, and without function, there is no form. So when we're planning, when we're actually carrying out the cases, you know, I think you really need to think about the form of the case. In other words, we're talking aesthetics, you know, what is the overall form of the teeth that we're working on? And of course, never lose track of function, because function is something that will, in my opinion, make sure that we have longevity in our cases. So, you know, from the cases that I'm going to show tonight, I'm really going to focus on form, and I'm really going to focus on the function. So if we look in 2020 to what's new and what's important, what's new, and this carries on beautifully from, you know, last week's, I think, first of the series of SADA webinars that we're having around the country, is artificial intelligence, and how does it fit into dentistry, and how does it fit in specifically to aesthetic cases and aesthetic dentistry. And I think that really a lot of us are probably unaware of the presence and the effect that artificial intelligence is having already in dentistry, and of course the big part that it's will play going forwards. And then the next two go hand in hand. So we're talking about monolithic, and what I mean about monolithic, I mean about materials, that are used in a state where it's a block, or it's been pressed, or it's just one material for that case. You know, we used to overcomplicate aesthetic dentistry, in my opinion, and monolithic materials, both direct and indirect, have allowed us to work in a more precise and a more simplified way, but 100% to achieve better results, more predictable results. And copy and paste dentistry, and this is a term we use a lot in the DSD concepts. And what do we mean about copy and paste dentistry is really the understanding of taking natural algorithms, taking, you know, what nature has done so beautifully over the years is produce, you know, tooth form, tooth shapes, and using these tooth shapes, these algorithms, and copying it back into our patients' mouths in a predictable and a precise way. So what's really important, so those are the new things that we're going to be talking about tonight. But what's really important, as well as what's new, is of course that the cases are facially driven, that we understand how to do a facial analysis, and we understand the impact that the dentistry, of course, is going to have on that patient for a very long time, and certainly if we focused on the function. And so, you know, going back to the theme of tonight is make it count, because these cases, you know, if we do them well, are going to be there for many, many years, you know, 15, 20, 25, and 30 years. And our patients are going to be reminded every time they look in a mirror or every time they see a photograph what we did to them or for them. Of course, 2D and 3D planning is the crux of every case I do. You know, that without a 2D and without a 3D plan in my practice, we don't do any dentistry. And that is absolutely 100%. Of occlusion, we'll refer a little bit to, because of course this is the function element of the cases that we're going to present. And what I talk about MI, I mean minimally invasive dentistry, and I think that this is a term we all understand. It's a term that our patients expect, in my opinion, and certainly the more we expose them on social media to what's possible, the more they demand, and the more that it's our responsibility to make sure that all the cases, aesthetic cases, are responsible dentistry and are going to hold up not just from a functional point of view, but a biological point of view over a period of time. So why all of this? Why, you know, is it important? And I want to take you back a little bit in time, because again, I think that unless we have evidence of techniques, materials, protocols that we implement in our practice, and unless we have the ability to look back over a number of years and see how these techniques have held up, I think it's very important just to keep moving. And so my journey with DSD, and this tonight is not just about DSD, by the way, but yes, it plays a big part in how I treat patients. So my journey with DSD started 10 years ago. And in fact, my journey with monolithic restorations actually started many, many years ago, because let's remind ourselves that gold is a monolithic material, but we're not going to talk about gold tonight. But my journey with monolithic actually started exactly the same time as my journey with DSD, which was 10 years ago, because I saw this patient very recently. And this was the very first case that I did a full upper arch of monolithic Emax restorations, and the very first case I did with DSD. To be honest with you, it was cumbersome. It took me a long time. I wasn't convinced at the beginning, but 10 years later, it's 100% changed my life. And if we see let me go back, sorry, if we see the pre-op picture on the left, we see the mock-up on the top right, we see the very first type of DSD that we used to do, that these are ones that I made before the DSD group came along. You'll see that 10 years ago, we were doing guided tooth preparation. You know, in fact, 2003, through Galep Gurel, we first were exposed to guided tooth preparation. And this is where it all fitted together. And on the bottom right, you'll see the very first Emax restorations.
Doctor, sorry to
yes, that's
You're
right.
not anything. We don't see any video.
Oh, there's no video.
Not at all. We thought you were going to read.
No, there's no video. But if there might be some videos down the line in the chart. I'll tell you when there's a video.
Great stuff. Okay, thank you.
That's okay. That's no problem. So really, what we're looking at on the bottom right were the very first Emax restorations, very first monolithic. So remember, these are stain and glazed restorations with no layering. And so
you're not sharing any screen, Doctor. Bottom right, bottom left. So confused.
Yeah.
Sorry.
Yes. Yes. Oh, okay. Sorry. Well, okay. Sorry. I can see now that we have to go back. Sorry about that. I asked someone to tell me. Okay, that's fine. We're going back. So I'm going to go back and I'm going to just very quickly. Okay, can you see it now? Okay.
Yes, we can.
Sorry. If someone had told me, I can see my screen beautifully, by the way. We had this conversation earlier on. So the first part of the presentation I'm going to run through, you know about Make It Count, you know about social media. So make it count is what I'm saying. And so every case that I do, I make it count for the patient, not for me. It's the patient that we have to look after. So again, going through artificial intelligence, monolithic copy and paste, facially driven dentistry. Can you see my screen now, by the way? I'm so sorry about that.
Yes, Dr. Bowles, we can see it.
Oh,
yes.
Sorry. Okay, so no one told me. I was seeing my presentation beautifully, by the way. So I had a great time. So we go through artificial intelligence, monolithic, copy and paste. What's important, I've already highlighted, facially driven dentistry, 3D, 2D planning, occlusion, minimally invasive. So here was the slide that I was talking about. First case ever, DSD, 10 years ago. It was clumsy. It took me ages. I wasn't convinced about it. But I did it because I understood that we needed more control when it came to communication with the patient, with the lab. And so on the bottom left, we were doing guided tooth preparation many years ago. And on the bottom right is the first case of monolithic. These are the first time that we just went to single state porcelain, no layering, staining and glazing. And still at this point, I have to say, I wasn't convinced. But I had the privilege of seeing this patient just the other day, which was 10 years down the line. And you can see on the bottom two photographs how these restorations have held up in the mouth from a functional point of view. No chipping, no wear, beautiful aesthetics. But more importantly, the highlight of this case is that I made it count, because if you look at this lovely lady and you look at her Instagram, look at all the beautiful pictures that she has. And this is something that we have to understand, the power of what we can do for our patients, or the power of what we can do if we don't get it right. So the essence of tonight's talk is make it count. Right. So now that you can see, I'm super happy. And this is the crazy thing of sitting in a room on your own, looking at your computer, because if I was in a room with, I don't know how many people are watching tonight, and my slides weren't moving, you all would have been screaming at me. But anyway, tonight we're telling the story of three lovely patients that I've had the privilege of treating. Jean, Maggie, and Jacob. And their cases are very different, but there are a lot of similarities that we're going to see as we're going forward. So let's start with Jean, and she was a case that came to see me. And really, if you look at this case, this is for sure a challenge. To give you a little bit of history, she's missing her laterals. And this is an amazing topic that I was speaking with Howie just recently, that we'd love to run a workshop of how do we treat patients with missing laterals. In fact, I've got two cases tonight. But getting back to Jean, she had, in my opinion, two very successful bridges done, cantilever bridges, full coverage VMKs, that have been there for more than 20, 25 years. So when I see patients with dentistry like this, we don't talk about failure. I talk about success. I say, wow, how amazing it is that work that was done so long ago was so successful. And so patients feel much more positive about about dentistry rather than talking about the bridges that have failed. Because really, as I say, they failed from an aesthetic point of view. So she has other problems, obviously. You know, she has a high aesthetic demand. She's come to me because she wants to make the dentistry count in her life. So we can see the laterals, we can see there's a small gap between the centrals, a small diastema. We can see the rotated premolars, which obviously are going to become a different tooth, but we have to decide for the patient the different treatment options that we have here. Because as we know, that with missing laterals, there are many ways to treat these patients. So the other thing that we have to understand in aesthetic dentistry when we're doing facial analysis and we're deciding, you know, where is the best place in this patient's mouth or face for the teeth to go, is that the smile is dynamic, and it's very difficult to make a decision for a patient based on one photograph, because you can see from the series of pictures that the situation is very different, and the information that we get from these pictures is very different. And so in an ideal world, in our practice, we utilize a lot of video because it allows us to understand the elements that might become super important other than just looking certainly in the mouth or just one facial picture. So we talk about dynamic smiles, and we talk about understanding the ability to analyze a dynamic situation. So in this case, the treatment options, if we think about it, was orthodontics to close the space between the 1-1 and 2-1, so the small diastema, and then implants to replace with the two laterals. Certainly that was an option that we thought about. Option 2 was ortho to close the space between the centrals and move the canines into the lateral spaces, which is a common way of treating missing laterals. And as I say, I can't go into that too much tonight, but it's a great topic for a workshop or a webinar or a course. Treatment 3 was orthodontics to redistribute the space and then prostho. In other words, you know, to try and close the spaces up so that they were evenly, and rather than have Pontics or implants, to do just prosthodontics to close the smaller spaces. And treatment 4 was no ortho, just prosto. Now bear in mind, in my opinion, that always my aim for my patients is to do the least amount of dentistry, and a lot of you have heard me say this, but I feel very strongly about it, to do the least amount of dentistry, but to make it count or to give them the best result. So I thought long and hard about this, and in fact, in this case, we chose to do no orthodontics and to just treat the case with prosto, which was a challenge. And, you know, I think one of the things that we're going to go back to is about DSD and about what's really new. And so, in fact, I believe this has just been released. When we used it, it was beta testing. So we now have an app on my phone to do the DSD using artificial intelligence. And so the first DSD case I showed you, that DSD probably took me, in all honesty, probably close to an hour to do it. Whereas now, using artificial intelligence, using the app on the phone, as you're going to see now, I can do a DSD in 60 seconds. Have a look. This is real time. So what's really amazing is that the app recognizes whether it's a young, old patient. As you can see here, they don't say old, they say mature. That's a little bit kinder. It understands the shape of the tooth. So you can see that we have square, triangular teeth. It's choosing these options for me. So I can override it once the artificial intelligence is kicked in, which it did. It proposed a smile for me, and now I have the opportunity to change it. And you can see the smile donator element going on here, which we talked about, copy and paste. And the amazing thing is, I think we have J-Lo, we have Julia Roberts, we have a bunch of celebrity smiles that we can use, plus Jan Haito smiles, there are a bunch. And then we can control the color And I think that this is an unbelievable, real simulation of a 2D situation that I can present to the patient in the lab before we go further. So that was a 60-second DSD. So for someone to say they don't have time is now sadly a feeble excuse for DSD. So from the DSD, in this case, we also did on the app, which some of you are familiar with. And I want to introduce you to another concept of facial flow, which I think is really, again, super important and is built into the artificial intelligence in the DSD apps that we use. So this is a built-in concept, and it analyzes the face, because I must remind you that most of the time, you know, smiles are designed or planned for our patients, and certainly this was the concept, that we use straight lines and mathematical numbers to generate a smile for the patient. But what we have to understand is that our patients, the vast majority of us, have asymmetric faces. So to design smiles with straight lines and mathematical numbers is impossible. And we have to understand about facial asymmetry. And in fact, with the facial flow, there's the article was written, in fact, by the DSD team, Bruno Pereira, Eduardo Mann, Carl Stanley, and Christian Coachman, in the Journal of Restorative Dentistry, Prosthetic Dentistry. And what they did is they used 4 facial reference points: glabella, the tip of the nose, the philtrum, and the chin, to understand exactly what were those facial asymmetries and build them into the smile. So the smile becomes more harmonious, more natural, and more organic, rather than simple straight lines and mathematical. And this has really been, again, something that's changed hugely the results that we get. So as you remember with the case, she had pontics in the laterals of the canines. And so where possible, in fact, most of the time, if we go to bridge work, we're going to create ovate pontics. And what I'm showing you here is that in order to create an ovate pontic, we need space. And you need 2 millimeters of space where the pontic development or the pontic site is going to be developed between the soft tissue and the bone. And if you don't have this 2 millimeters, you need to open a flap and create the space for the pontic development. And when we're creating these pontic sites, again, what we do is we don't just use pressure, we use an incision. And so we use a buccopalatal incision, which is all the way to bone, and a mesiodistal incision, as you can see on this diagram, which is a split thickness. And if necessary, and we need to create an osteotomy, I'll do it through this incision to create space for the ovate pontic. Also, at the same time, we were changing the preparation type of the canines, which were old VMKs, and for VMKs, we had to do horizontal preparations. We were changing the preparation from a horizontal preparation into a vertical preparation. So when you look at this canine, what you can see there is no margin. And so this is the biologically orientated preparation technique that was written up in the European Journal of Aesthetic Dentistry in 2013, which explained this protocol, which is no question a much more minimally invasive way, but also the tissue response and the prosthetic response that we get is without question superior. So from the 2D design, we did a 3D design. We milled PMMA temps. So this is, again, another monolithic material that has entered the market that's helped us. And so we did, in this case, print a model. And here we're developing the pontic sites with the PMMA. And what you'll notice is that we're also positioning the margin of the abutment canines in a way that we can coronalize the tissue through the BOPT technique. So we're going to fit these temporaries, and then I think I left them there for about 2 months. The tissue coronalized, in other words, it came down towards in an incisal way without doing any soft tissue grafting. So after 2 or 3 months, when we were happy with the Pontic development, what did we do? We went through the PMMA attempts, guided tooth preparation for control. Again, we thank Philippe Gurel for that in 2003. So this is, again, nothing new. Using indexes, controlling thickness, controlling embrasures. And again, this is something that we do for every case. You know, there is no dentist who's good enough to do this sort of dentistry without guides, in my opinion. Well, that person doesn't exist. So we scanned the case. Again, the digital workflow has really changed a lot for me. And I know everyone's in a transition phase as to where they are, but I do believe that it won't be long before everyone is working like this. And you'll see the canines, we have vertical preparations. The centrals, we are doing 2 veneers to close the diastema, ovate Pontic development, and a minimal prep on the premolars. So this was the case finished. I think this was about probably 3 or 4 months afterwards. What do I love about it? I love the integration of the tissue. I love the form. I love the function. We've taken the guidance onto the canines. I love the aesthetic side to it because we've made it count. Is this picture important? Not at all. For me, you know, for dentists, they might like looking at what's really important is we need to see the facial integration. We need to see, you know, how successful that case was for that patient. And so going back to the theme of tonight, in my opinion, for this patient, I definitely made it count. Planning, materials, and the digital workflow that we used. And so this, I think, is about a year follow-up. And just to give you some experience now that I have 10 years with Emax, my personal experience, this is not a research, this is not it's a personal kind of investigation into all the patients that I've treated. Obviously, some have moved away, so I can't tell what happened to them. But 10 years, we've done over 4,000 restorations. And in fact, that's over 99% success rate. I think it worked out to about 93%. I believe that if you look at Emax, they've done overall 120 million restorations over a 10-year period, with, I believe, a 96 or 96% success rate. Again, I don't believe there is another material that's been as successful as this monolithic state of ceramic. So that was the first case. Let's talk about Maggie. Maggie came to see me, a very different case. She came to see me. She was referred, in fact, I believe by Howard, Dr. Gluckman, because she had come with the understanding that it was time to consider having her bridges replaced with implants. And so when we have a look at it, we can see that, you know, there's a lot of problems here, not so much maybe with function, but a lot with form, that a lot of the shapes of the teeth obviously have got out of proportion to how they should be. And we understand, if you understand about form, you will be able to determine that. If we looked at an occlusal picture, what do we see is that she has 3 bridges which again have been successful. Yes, they need replacement, but they haven't failed. And so she understood that it was time to move on. We can see some chipping of the porcelain, and you can see that she's had to go through some endodontic procedures through the original bridge work with posts placed. And yeah, I think that our initial reaction for the case was that we were going to replace these with implants. However, remember what I said about doing the least amount of treatment, but giving the best result. Once we had a look at the CBCT, we notice, yeah, a huge defect that, in all honesty, to graft that, multiple surgeries, long treatment time, and yeah, it's possible, but you know, the question is, were there any alternatives? And so if we look at the treatment options for Maggie, in my opinion, we could have gone through the bone augmentation implants and implant bridges, which is exactly where we thought we were going to end up. Alternatively, we could have extracted the abutment teeth. We could have placed implants in these sites. and placed an implant bridge with pink porcelain. Certainly a shorter treatment time, less aggressive, less surgeries. Third option is replacement of the old bridges. And the fourth option was a removable comb denture utilizing the existing abutments. So, you know, those are all valid treatment options, but, you know, if we look at the evidence, and the evidence was that she had had 3 bridges which have been entirely successful other than some endodontic failures on the teeth, which is understandable, and some minor chipping, but they had been really successful for, again, over 20 years. And so in this case, we decided, you know, with the help of the team and given her all the information, we made a decision. She made an informative decision that in fact we were going to replace the crown. So using artificial intelligence, you'll see. Again, this is a 60-second process, but it's the start of every case. Mature triangular teeth. And it's going to propose a smile for me, and then I have the option to change the positions of the teeth, the dominance, the smile curve, the smile arc, and I have a possibility also to change the color of the teeth, and also to introduce pink if we're going to use pink porcelain, which you can see. And so within 60 seconds, we had generated a very achievable, very realistic, but a solution that was going to make it count for Maggie, in my opinion. So the rest of it was just now the implementation of the bridge work. So again, we took it off. What did we do? Again, you've seen once before, we went from horizontal to vertical preparations, and we provided through a 2D, 3D with a treatment planning process, a new temporary bridge. When the temporary bridge had been there for a period of time, she was traveling, we now needed to go forward to the final bridge work. And again, here's the third material that we are introducing tonight, which is a zirconia. And by the way, there's no conflict of interest. I've not been paid by any company. The materials that you see in this presentation are used in my practice because, in my opinion, they're the best materials for my patients. So it's an honest overview of where we are in aesthetic dentistry. So why do I like Zircad Prime? Because I love the aesthetics. You know, if we go back to Emax, it wasn't strong enough for bridge work, in my opinion. And that's the results. We had fractures over the years. Zirconia was an amazing material, but for many, many years, it was strong enough, but the aesthetics was very poor until the aesthetic translucent zirconias came on the market. And certainly one of the most recent Zircad Prime from Ivoclar is an amazing material because it really combines both strength and high-end aesthetics. Aesthetics comparable, in my opinion, to some of the glass ceramics. And what's unique to Zircad Prime is, instead of a layered process where they layer different layers of opacity of zirconia on top of each other, we have a gradient kind of technology, which makes it much more real, going from the dentine to the enamel. And as you'll see, that really it is, in fact, you can use it for full contour, full arch, 3-4 unit bridges, and they give you all the limitations, certainly, with it, using either staining technique, cutback technique, layering, or infiltration. So we went back on a PMMA. Here's again monolithic new materials that were developed, milled restorations, PMMA with some pink. And now what we're seeing is the return of form and function, or form and certainly function. After a period of, I think, 4 months, 3 or 4 months, she came back, and we're ready now to transition from temporary to a permanent. And so again, this was a big problem because we lost a lot of detail. but using digital workflows, this is not the case. And please have a look at this, at the tissue response to the vertical preparations that we see. You do not see this with horizontal, and to cut horizontal preparations, yeah, we would have totally destroyed these teeth, in my opinion. So again, we scanned the case for the final bridge using retraction standard. If you're scanning, standard retraction techniques are applicable. So double cord, the first cord is a vertical cord, and the second is a horizontal. That gives the space for us to scan. So, you know, for those of you who think that scanning is a limitation, I don't believe that's the case. But we wanted to copy the beautiful aesthetics that we had achieved in the PMMA. So what did we do? We pre-scanned the original bridge. We then scanned the bites, scanned the preps, and then the lab then used that to generate a file to create the new monolithic ZirCAD bridge work, which obviously we fitted. And so the beauty of scanning, again, it allows us to look at the possibilities of undercut on the teeth before we send this off to the lab, because if there's undercut, obviously path of insertion is going to be a huge problem, certainly on these long preparations. So with the scanner, it allows me to evaluate undercuts, eliminate them, rescan, and then off it goes to the bridge work. And it came back, and I have to thank my technician, Shane Hansen from Diceram. He has an amazing understanding, amazing ability to produce some of the most phenomenal restorations for my patients. So again, what you're seeing here is monolithic, and look at the gradient technology, look at the beautiful incisal translucency and the opacity of the dentine, and that we see in the vertical preparations. And again, the material mills, and without this sort of material, it's not possible to mill feather edge restorations, in my opinion. So more importantly, if we look at the integration of the tissue, and why is it so good for vertical preparations? Because what do we know about zirconia? Zirconia is that the body loves it, the soft tissue loves it. So putting this material subgingival is a dream. And so again, I think that if you look at this integration of the tissue, both on the Pontic site with the pink porcelain and the abutments, as you can see over here and here, is phenomenal. Again, what's new is that, you know, if we're loading a case like this, we want to make sure that we're loading these bridges through the right teeth and in the right areas. So, you know, again, this has changed my life, is the ability to analyze the occlusion with a digital technology, with a T-scan. And of course, what's really important is I made it count, you know, and there's a happy patient because we planned the case meticulously. We used new materials that worked in our favor, and we understood, as I say, the plan right from the beginning, and just followed it through. So I know that took a few extra minutes at the beginning, so I might be running about 5 minutes late tonight. I'm so sorry about that. But let's get on to Jacob. So this is the last case that I'm going to present tonight. And again, it's a very similar case possibly to the first one, because he's a patient with missing laterals, which I don't know, but maybe it's what I see, but I see a lot of these patients. And here we chose to treat it, it was treated differently. I didn't do the orthodontics, but the canines were obviously moved into the lateral position. And so now we had an aesthetic challenge to fix. And so he's a young patient, and we have to really be concerned about you know, making sure that the choices that we make for him are as conservative as possible, but give him the best outcome in terms of form and function, you know, sticking to the rules that we talked about. So if we look at Jacob's treatment options, the first one was to do orthodontics. Having said that, he had finished orthodontics 3 years ago, to open space for implants and replace laterals. And, you know, in my opinion, and this might be controversial, and it's time to, this would be my last choice. Ceramic veneers on the front 6 teeth, that's a possibility, but remember his age. Direct resin restorations, so this is a great option, but again, it's technique sensitive. You know, I think that we have to have huge operator skills to apply direct restorations into this mouth, and to make them look as though the canines are laterals and the premolars are canines. So we have to have a high skill. This is really a tough challenge, but really possible. Or digitally planned 2D, 3D, indirect and direct restorations, but using the technology to injection mold. So what does that mean? Is it means we're utilizing the plan to control the form. We're not using our hands. And I'm not saying that I don't have the skills, but again, it's something that I think has become more reliable and more precise. So again, this one took me 80 seconds to do. I don't know what was happening that day. So we obviously load the picture and we set the smile curve. We then go to the artificial intelligence. It's picked already. It's a young patient and he needs triangular teeth. So it's now going through the process of deciding where in the patient's face is the best place for the smile, given all the parameters, midline, we've set smile curve, the lip, and it positions them. Now I have the opportunity to make small modifications to the dominance of the centrals, to the occlusal plane, to the smile curve, to decide which teeth we should have. I nearly gave him J-Lo's teeth, but decided not to. We used a smile donator, and now we just changed the color. And so that's how simple smile design has become. It's phenomenal. And so just going back while we're waiting for that, is remember that when we scan our patients with our intraoral scanners are loaded with artificial intelligence that help us scan in a direct way. So here we design with transparency. We can see exactly where the restorations need to go. We can exactly see the new form of the restorations. We have concerns because we're moving guidance from onto the premolars. We can see there's diastemas, and we're going to give him canine guidance to protect our anterior restoration. So my concern was about longevity. And in this case, I decided to go with resin on the front 4 teeth, ceramic on the premolars, and turn them into canines to give him guidance. So we printed some models, and the 3D process is that we can now take the model and we can eliminate 2 teeth. And so this is the process of injection molding. We eliminate the alternative teeth. We then take a clear silicon material, and my material of choice is Exoclear from GC. And then we create 2 indexes, which we make small holes through the index. I think most of you are familiar with the technique. You know, the material that I choose for injection molding, again, it's a material that's been developed specifically for monolithic direct restorations, which are generated from a digital plan. And the reason I choose this material is because of the strength and wear resistance that it has. Opacity, color options are amazing. Color stability is amazing. I think all of them have good shrinkage these days, limited shrinkage on curing. I love the extrusion pressure. In other words, it's not too viscous, but it flows, and the ease of finishing and polishing. I won't go through that. It has a nice range of colors, but the complications we had here is that we wanted to end up as A1, and you can see that the incisors, his centrals are very light, but as we would expect, his canines are warm and highly chromatic because of the dentine. And we're going to have to change that tooth to an A1, and that was a challenge. So again, the materials were developed, and it's a bit like ceramic. You know, when we choose ceramic, we have different translucencies and opacities that we choose for our patients. And so we chose a dentine color and an enamel color for the incisors to marry them up. We did some testing to see that it was going to work. And then we covered the alternate teeth, we put the index in, and then we inject. Okay, just like the whole amount. I can't go into the technique tonight. I'm really highlighting the material and the design. You know, this is a copy of the design rather than freehand, because, you know, I think dentistry is moving away from freehand dentistry, and more to digitally planned dentistry, either from milled direct restorations and soon to be printed restorations, in my opinion. So that's what the index looks like, the alternative teeth. We remove it, and because it's so accurate, as you can see, there's almost zero cleanup. Okay, so we just remove the excess tags, we polish and clean interproximally. And that's how simple that case ended up. And so we ended up with 4 injection molded anterior teeth. Remember, these are the laterals are the canines. Look how the color is integrated. Remember the chroma, high chroma of these teeth. And then I placed monolithic, again, Emax restorations on the premolars, changing them into canines because we were providing all the guidance on these teeth. So in other words, we were addressing form and function, and it was a conservative option for him because we reduced the costs on the injection molding instead of ceramic. We had complete clinical control, and it's affordable. And I think in these days, this is really super important. But what's more important for Jacob was I made it count. And you'll see there from an aesthetic point of view, he was super chuffed with the results. And it was a minimally invasive, controlled, planned execution of digital dentistry, but using direct and indirect restorations. So yeah, that's almost me done. I know that I've gone a little bit quicker. We lost 10 minutes at the beginning. And I'm obviously more than happy to answer all the questions that I hope they are at the end. But let's talk about my last case. So you saw my first case with DSD, and I'm going to show you now my last case. And again, you know, the emphasis on all of these cases is that I am determined, you know, to make it the best possible case for each patient. So that's my focus. And so this last case was a super special case, as you'll see, because those of you who know me, or maybe know my patient, yeah, it took over 30 years for her eventually to get the opportunity to sit in my chair, for me to do some work. But again, nothing different. What do we see? Top left corner, facial flow, understanding about harmony, and not trying to make smiles mathematical. What do we see? 2D plan. Okay, what do we see? A 3D plan. And then guided tooth preparation. And now look what we've moved on to. You can see these are digitally orientated tooth preparation guides that make sure that the tooth preparation is meticulous, so that we can create exactly the restorations that we've designed at the beginning, so that the thickness of ceramic is what's important. And this was a challenging case because you can see, I think her brother broke her tooth when she was a teenager, she won't mind me saying, and she ended up with an endo and a gold post, which has been there many, many years. So this is a success. But handling now color with these problems is a really big challenge. And again, that's for another lecture. But for sure, I was under pressure here to make it count. And I'm happy to say that was for sure the case, you know, and I think you'll agree with the outcome. So what's really changed, I think, in dentistry over certainly the last 10 years that I've been exposed to this change from layered or you know, certainly direct and indirect layered restorations, which were time-consuming, laborious, that only certain dentists and technicians had the skill in producing, and which meant dentistry was exclusive for patients who could either afford it or were living in the right place, to the modern era of dentistry, which is progress, in my opinion, where, you know, we're utilizing natural algorithms of beautiful teeth. We're copying and pasting them into our patient's mouth in an indirect or direct way, which has made dentistry inclusive for dentists and patients. You know, and I say that really the focus, as I say, for me is, again, yeah, is inclusivity for my patients, to make sure that we get really the best result always. So, you know, I think we've covered about a lot of stuff tonight, and really it was an overview, but the most important things, I think, well, not I think, I know, is obviously the help of artificial intelligence is playing in our lives. Planning is really a hugely important thing. Understanding about facial integration, understanding about facial asymmetries and facial flow, understanding about minimally invasive dentistry when we look after our patients' teeth, but more importantly, when we get, or when our patients trust us with this opportunity to give them something that they're really looking for, that we make it count time and time again. You know, and I think that if I'm giving some advice to dentists, young or old today, and the future of dentistry and the things that they really need to focus on to make sure that we all grow as a profession, as individuals, as our practices, that we must focus on efficiency, because this will make us more profitable and more productive, but in a reliable way. And again, this is DSD digital workflows that we're using. And I think differentiation to make ourselves stand out if it's possible. So if we can focus on efficiency and differentiation, I think the future for dentistry in our hands is in all honesty bright. And so the good news as well is that, you know, that we're now planning some courses, going back through the Implant Aesthetic Academy. Before the end of the year, we'll be putting some dates together for DSD restorative courses, a Style Italiana course for direct restorations, injection molding. So, you know, for those of you who'd like some information on those courses, please, courses@enameldentistry.co.za. And yeah, I'd love to just give you even more information about a lot of the topics that we talked about tonight. And again, not that that's really important, but I hope you enjoyed it. And I hope that there were just a few things, a lot of things that really maybe opened your eyes, maybe made things clearer, that made you understand what it is you need to do when you're tackling, you know, these cosmetic cases. But the good news is I'm not going away, and I'm here to answer as many questions as you'd like. So thank you so much, Limpopo branch. Thank you so much, SADA, again, for everything you've done for dentistry this year. And yeah, it's been my pleasure and privilege and honor to just share some of my information and the experiences of those 3 patients with you tonight. So I'll stop sharing. How about that?
Thank you very much, Dr. Bowles. You've really shown us that simplicity is the ultimate sophistication. And I think Prof. Marala, who was our presenter last week that presented in the Gauteng South webinar, will be quite happy to see the impact that artificial intelligence has had on dentistry, I mean, and the evolution that is coming up in dentistry. So I think without wasting any time, we will address the questions. We had a few technical glitches in the beginning, so I'm just going to apologize to everyone, because I think about the first 15 questions were about the glitches that we were experiencing, but nonetheless, we managed to sort that out. So Dr. Bowles, one of the first question that we have here is, what about the active frenum? I think it's with the first patient that had a diastema. So Dr. Pretorius wants to know, what about the active frenum?
Yeah, so I think in a case like that, obviously the attachment of the frenum wasn't really right into this, the space between the centrals. So it was high, I agree. And if the frenum had gone right in between the centrals, then yes, I would have been certainly anxious about closing the teeth if I'd chosen orthodontics. But you know, given that we were using a restorative option, and the frenum hadn't complicated the patient. In fact, the patient hadn't complained about it, and it wasn't an aesthetic issue. Of course, we decided to leave it because, you know, again, I'm trying to do the least amount of dentistry I can. So that didn't impact on the restorative work that I was doing. But certainly, if I'm closing it to AI, I would have taken a different view.
And then we have a couple of questions, Dr. Basil, a couple of our members that would like you to go over the vertical and horizontal prep. One doctor actually asks if horizontal and vertical prep are shoulder and chamfer prep.
Okay, so a horizontal preparation is what we know as a shoulder preparation, which was the preparation of choice for VMK crowns, for those of us who are still doing them, and certainly when I did them, I haven't been doing them for quite some time. But that was the preparation. So a chamfer is a preparation where we're really looking for possibly an Emax restoration, whereas a vertical preparation, and again, for those of us who are a little bit older and used to do gold work, for instance, so vertical preparation has no margin. Okay, so we take away the margin completely. So there is no margin. So we then can determine where the restoration finishes. Okay, so we can decide with the technician where exactly we would like to place the margin of the restoration. And that could be supragingival if we're looking for a coronalization of the gum, of the tissue, or it could be gingival at the gingival height, or it could be subgingival if we're trying to hide the color of the tooth structure. So it's a kind of a foreign concept, but once you understand it, so there is no margin to the preparation. We take away all. It's not a chamfer and it's not a horizontal. So, yeah.
Okay. Thank you, Dr. Bowes. Our anonymous attendee would like to know which cement do you use for Zycat Prime Bridge and crowns?
So I'm going to use a resin modified glass ionomer, I think is the best, because most of these vertical preparations we are placing subgingival. So I think it's impossible to go with a full adhesive protocol and use resin cements because of moisture control. And so again, if you're looking at tissue response, there's no question that resin modified glass ionomer cements react better to tissue than resin cements. Having said that, if you're working accurately and you're not leaving cement behind, I'm not sure that it makes that much difference, but a resin modified glass ionomer would be my choice.
And then anonymous again would like to know, Dr. Bowes, how you transfer the artificial intelligence plan to the laboratory.
Okay, so if you're working with the DSD protocol, which is obviously what I do with the app, we have two options. So we can either take a screenshot, okay, and everyone knows how to take their phone and take a screenshot of the design, yeah, and then you can WhatsApp them, you can email it, or it's possible through the planning center is to actually email them the whole presentation. But the easiest way is to take a screenshot of the design and then email it to them, or WhatsApp it to them, or we transfer it or whatever. But that's how I would do it, certainly to a local laboratory. Okay.
Okay. And then Dr. Pretorius would like to know if Jacob's teeth were slanting to the right.
It might have looked like it. I'm happy I would go back, but from the facial shots, no. It might have looked like it on the intraoral, but again, I think we have to be very careful to analyze intraoral photographs. That's my opinion. Yes, we can look at them. We can look at them to see that maybe we've not left cement, or we've not polished it, or something else is a problem. But ultimately, the analysis of the aesthetic outcome can only be done with facial pictures. And so from a facial, there was no problem with the midline.
And we've got Dr. Harry Passat there, thanking you for an amazing presentation, Dr. Bowes. And then Anonymous would like to know when the next DSD course will be.
I believe if they could get hold of courses at enameldentistry.co.za, but I believe October. Let's hope and pray that this whole fiasco disappears sometime soon. And so I think October is the first time that we believe that it will be safe, to all get together in that sort of environment. But obviously safety is the key issue. So, yeah. So hopefully October.
Okay. And Dr. Maria would like to know which luting cements do you use?
So again, if we're going back, I think we've covered the vertical preparations on the bridge work, and let's remind ourselves that when we're doing these sorts of preparations on bridges with vertical, that retention isn't a problem. So we have retention in the form of the preparation. However, when we go into our minimally invasive ceramic restorations, then we will go to full adhesive protocols. And there I will use the VeriLink aesthetic cements, light cure if possible. So I always prefer to work with light cure cements rather than dual cure. So my choice is VeriLink aesthetic, yeah. Full adhesive protocols, though, full adhesive protocols. So, selective etch and bonding protocols that we all know with universal bonding.
Okay. And then Dr. Maxson is asking, when you do injection molding, do you make a series of templates depending on which teeth you are building up, or do you use the same template for the whole treatment?
Okay, so when injection molding was first brought onto the scene, what often happened is they made one. And you must remember that when you, and this is again the development of planning and digital planning, that when injection molding started, most of the cases were done on plans or models where wax had been applied. So the problem with wax, in my opinion, is that your technician then had to do 2 wax ups, one with alternate teeth and one with all the teeth. So this was not possible. So when we were doing them with wax, we had to do all the teeth together. And the problem with this was controlling the interproximal spaces. Okay, and this is why the technique took a little while to gather momentum. And it really gathered momentum when we started to plan the cases digitally, because when the technician is doing a 3D plan, it's the click of a button to remove alternate teeth from the design. Okay, so that we have one tooth that's designed and one which hasn't been designed. And we went round the model, and this takes no time at all. And then we would generate a model with just alternative teeth, so that when we injection mold, we do alternate teeth, not all together. And that meant that we could cover the teeth we weren't building up with Teflon tape. And so so that controlled the embrasure spaces for us. So we use 2 models, one with alternative and then one where we fill in the rest of the teeth. So that would be the second model, which would have all the teeth in the design. And then we would cover the teeth we had built up with Teflon so that we didn't get composite on top of them. So this changed everything, yeah.
Okay, and then Dr. Pinheiro, I hope I pronounced that correctly.
Perfect.
Dr. Pinheiro would like to find out if the Style Italiano courses are going to be presented online.
So the answer to that, is and we talked a little bit about this. The emphasis with the Style Italiano course was that it was a 2-day course, and over 70% of the course was a hands-on element. Because I think direct restorations, in my opinion, are really one of the most difficult things we can do, certainly from an aesthetic point of view, but also from a posterior point of view. And it's one of the most important parts of restorative dentistry today, because it's what our patients can afford more often than not, that they can't afford ceramic restorations. And so the challenge really is how, do we do, 70% of a 2-day course online, with this hands-on element. So, we thought about different ways of doing that, and as of yet, no. But the intention is actually to have a Style Italiano course, a 2-day direct restorative course in Joburg in October. If again, it all happens. So, yeah.
Okay, thanks, Dr. Bowes. I think I'm going to take the last question, and then I'm going to hand over to Dr. Khan Patel to go through the rest of the questions. Okay. Here's another compliment, Dr. Bowes, and then 3 questions from Anonymous. The first one is, which smartphone do you need for DSD? The second one is, what is the best intraoral scanner?
Mhm.
And the third one is, how do you finance all the digital equipment?
Okay, so the last question is a really good one, but I'll answer all of them, of course. So at the moment, iPhone is what sadly it's on. I believe that it's very soon that we're going to be able to get a version that will work on Android. Okay, but at the moment, it's an iPhone, an iPad, and soon to be a Mac as well. So there's an Apple preference. I can't help that. The second question was, just remind me quickly. Oh, how do
The
I
second
finance
question,
it?
No, Dr. Bowers, the second question is, which is the best intraoral scanner?
Okay. So,
Yeah.
you know, I'm again, you know, I'm not biased because I use 3Shape. I think 3Shape is an amazing scanner. Having said that, you know, there's any one of probably 5 or 6 or scanners available in South Africa, which are as accurate, or certainly accurate enough to scan for the restorative work that I did, that I showed. So, you know, again, I think there are a number of things that you need to look at when you're buying a scanner of what you're using it for. So, for instance, you know, if you were doing Invisalign, then you would buy iTero, not that it's available here, but, you know, that you have to look at your laboratory and see what software maybe they're using that will accept your scans easier for you to be sent. As far as so I think that there's a lot of most of them are these days are accurate enough. I don't have a problem. And again, I don't need to mention any of them. I think they're all amazing. They're all accurate. I think backup is really important, you know, so you have to look at who's going to help you when something goes wrong. That's really important. And I think some companies are amazing in South Africa. I'm not going to mention too many names, but you need to look at what's the backup of that, you know, scanner that you're buying. But the one thing that I would say, you know, that I think sets, in my opinion, 3Shape apart from the other scanners, and you know, I'm open for this debate, is the software. You know, that the software that's available that 3Shape have is certainly unique to 3Shape. And I'm not talking just about the scanning software, I'm talking about patient monitoring software, you know, where I can actually scan my patients and tell them what's happening in their mouth, whether their teeth are wearing down, whether their teeth are moving. And so I think the software that 3Shape has at the moment is superior, not by a long way, but superior to other software, but they're all moving quickly. And, you know, I would be honestly happy with one of maybe 5 different scanners in my practice, but I like 3Shape, and so yes, if someone had to push me, I'd say 3Shape.
And then the most important question, Dr. Bowers, the financing of the digital equipment.
So that's a great question, because actually, you know, you don't have to have an intraoral scanner. This is really the key thing. It's possible to do all of that dentistry I showed tonight without scanning your patients. You know, you must remember that our labs have been, most of them have been working in a digital way for many years. So most of the labs have benchtop scanners. So you can take an analog impression and you can create a digital file of that patient. So in other words, you can create a scan STL file in the lab. And then go into the digital workflow that I showed, you know, designing, doing all of that work and getting back a file from the lab, which is printed. And then when you prep the teeth, you're going to use all your prep guides, but then you can either scan the patient or take another impression. And the lab can then turn that back into a digital impression. So it's possible to do all of what I showed without having an intraoral scan in your practice.
Okay. Dr. Khan Patel, are you comfortable with where we are with the questions, Doc?
Yeah, no problem. I mean, I know that we started a little bit, we didn't get, so I'm more than happy to answer some more, no problem.
Dr. Davidson, you can continue, it's fine. It's not
Okay.
problem.
All right, okay, thank you, Doc. And then Dr. Bowers, here's I think one of the most difficult questions, but you can give it a try. Why is this type of treatment not taught in dental schools?
Yeah, it's very interesting, and actually, I'll be pleased to say that and we're talking that the only course that I was able to give this year, in fact, that I flew up to Joburg for, one of the senior lectures or head, I can't remember for the life of me, from Wits University was in the audience, and I didn't even know that, but she was super impressed, I have to say, and she understood the importance of what I talked about. It was a lot of similar things, so much so that she emailed me on Monday morning and asked me, please, could I come to Wits to do a presentation for their final year graduates. So, you know, the answer is that hopefully, you know, this will be something that is taught at dental school before long. You know, I think that, you know, obviously it's cutting edge. This is 2020 dentistry, you know, and so it's very difficult to teach undergraduate students absolutely everything that is available today. You know, I think it's important that we give them, you know, very good basic knowledge, and then, you know, I still remember that one of my professors said to me, you must understand that when you qualify with BDS, this is only the beginning of a learning process. That, you know, you will, and I still learn every day that I go to work. So, you know, again, it's I think very difficult to teach undergraduate dentists everything that is available in dentistry in 2020. So, but they are focusing on it, as I said.
But I think as well, Dr. Bowes, my mind is also starting to run around. I'm also thinking that maybe that's where SADA can come in. Maybe we can arrange this webinar for the final year students. So that is something that maybe we can look into. And then we have another question. Does your technician glaze or polish your zirconia for final stage before sending the case to you?
So if we're going to fit it, he's going to glaze it. Yeah, okay. That's our preference. And so I know that I saw a comment on even Emacs that it was suggested that so my problem with just polishing is that, you know, most of our cases have some element of staining. So if you're staining, and again, you know, I'm not a technician, but the problem is that if you're staining cases to enhance the aesthetics, then obviously to control that stain or to keep that stain, I believe you need to glaze. So we glaze all of our cases.
Okay. And then Dr. Becker wants to know, what cementation protocol do you use for PMMA, temporary crowns, especially for the purpose of tissue shaping that may take a few months?
Okay, so it's a good question, and it's a very simple answer that if you looked at that case that I did, the first case that we had, we had 2 cantilever bridges from the canines which had the vertical preps, and then the centrals, I'd created 2 veneers without even prepping the teeth. So those PMMAs were super thin but non-retentive, and really I love the PMMA because all you need to do, and again, you know, if these PMMAs are going to be there for 3 months, 4 months, then I would use a self-adhesive resin cement. So it's like SpeedSem or Reliax or Reliax. So self-adhesive dual cure resin cement. So all you do is you sandblast. So if it's non-retentive, I just sandblast it. And then if it's on the tooth, I just etch. I don't even put bonding on, you know, because there's a self-adhesive element on the cement. So just etching the tooth and sandblasting, and that won't come off.
Okay. Dr. Bowes, there's a lot of questions about the app being available on, I know you addressed this question to say at the moment it's only available on the iPhone, but we have a lot of questions that are speaking about the app being available on Android. And then we've got Dr. Moreng. I know Dr. Moreng is a registrar in prosthodontics at SMU. So she's got a question that she's asking. She's thanking, and then she notices that in all cases presented, you conformed to the patient's occlusion. How would you advise one to approach a case where there is a need to transform the occlusion vertically and horizontally, taking into consideration the vertical dimensions as well?
Okay, so that's a great question. If we had like 2 days. No, I'm joking. Yeah. So here's my reply to that. So, you know, if I'm doing a single arch, and certainly we're not changing the occlusion like these cases, then of course we're not going to change the vertical dimension. If I'm doing a full mouth rehabilitation, so we're changing the upper and lowers, and there are times where I will open the vertical just on one arch, but that's not really that common. But if I'm changing the vertical dimension of occlusion, which obviously is a change in a horizontal and vertical element, the one thing that I would say with getting it short and sweet is that I will always change the vertical dimension in centric relation. So I won't change the vertical dimension in centric occlusion. Okay, so I'll change the occlusion, I will find centric relation, and then I will open the vertical, and the amount of vertical that we open depends on the case. So there's no amount. Each case is different, and the issues that we have to consider are obviously the biology in terms of why we open vertical occlusion, vertical dimension of occlusion is to be more conservative, to have space for the material, certainly in restorative. Secondly, from an aesthetic point of view, that if we want to lengthen the anterior teeth, upper anterior teeth, then, you know, what you're doing if you don't change the vertical is that you are going to create a restriction in the envelope of function, okay, just by increasing the length of the anteriors. So from a functional point of view, opening the vertical creates a much better guidance pattern. So it's an aesthetic consideration, it's a biologic consideration, and it's a functional consideration that we take into account, but always in centric relation, because this is reproducible. And this is the most comfortable place for the patient to function. I hope that was a clear answer.
Yeah, thank you, Dr. Bowles. What technology do you use to measure the occlusal force?
So what I showed there, which is really, again, and again, it's not something I would use for single teeth, or even if I was doing maybe 2 teeth, 3 teeth. But when I'm doing full arch dentistry and certainly implant dentistry, I'm very lucky again that we have a T-scan, which allows us to determine digitally not only the force of the contact points, but also the time that the teeth come into contact with each other. In other words, which is the first tooth making contact, because this is really important in an implant occlusion. And certainly that case that I showed you, what I wanted to make sure is that if you didn't see it fast enough, because it was quite quick, that all the points of high contact, okay, were going through the abutment teeth, okay, on the long axis. And in fact, the highest points of contact were on her own teeth in the posterior. So, you know, it allows you to control not only the level of force, but the rate at which the teeth come into occlusion. And again, as I say, that's super important for implant cases, because you don't want your implants to touch first. You want your teeth to touch and then the implants to engage. And there's no other way than determining that. You can't do that with bite registration paper. So it's a T-scan is the name of the device. But I know Bosch also do one, which is a little bit cheaper.
Okay. And then Dr. Sachs would like to know, in the current South African economy, is the initial setup cost of the milling machines and scanners recoverable?
Yeah, so I mean, I don't have a milling machine, first of all. So that's a question that, you know, there's now places. I mean, I think, you know, that debate of, you know, who's the best person to produce restorations, is it, and this was a kind of old CEREC question, but, you know, I don't have a milling machine in my practice, first of all. And so, you know, this is outsourced to the laboratories, and I think they're the best people, in my opinion, to do the work that I do, because they have more knowledge and skill and time to do the technical side of that work. But I know there are dentists who are very skilled and who can take on that responsibility, but that's not for me. And so again, we covered this a little bit, that actually I can do all of those cases that I showed without an intraoral scanner and without a milling machine in my practice. Although they're complete digital workflows, I can take an analog impression and transfer that into an STL file and then work in a digital way. So actually there doesn't need to be an outlay if you want to work digitally. You know, you need to understand at what point you enter into the digital workflow, and then at what point you come back into the analog, or whether you want to go complete digital. So it's really important that you don't feel the pressure of having to buy an intraoral scanner right now.
Okay. Dr. Bowers, I think we only have like 5 minutes left, so okay. I'm going to cover 2 more questions and then we can wrap it up, just so that we don't take up more time. Dr. Lekalakala would like to know, or Dr. Lekalakala is giving a compliment for a beautiful presentation, and then the doctor would like to know, what is the best resin modified glass ionomer cement that you can recommend?
Yeah, so what I'm going to say is what I use. So I use Fuji Sam. So that's my preference. You know, I've been using it for a long time. I think there are a number of glass ionomer, resin modified glass ionomer cements on the market, but that's one that I can recommend, you know, without saying that it's the only one. You know, that's what I use in my practice, and it's worked phenomenally well. And yeah, that's what, if someone wanted me to recommend one, that's what I would recommend.
Okay. And then the last question that we're going to cover is, do you use digital impressions when using DSD?
So the workflow for DSD is that, you know, what I showed on the phone was that I didn't use a digital impression. I just use a facial photograph. But, you know, the alternative is also, even on the phone, that they haven't introduced it, but certainly on the app, I would design, so I would use an STL file, but you don't have to do that. That's not like one of the, it's for me, it's better. So I import an STL file of the patient into the design software, so that I'm designing on a model, but using the face. And only 2-dimensionally. You must remember that still, even though we have an STL file, we're still only designing 2D. Okay, so that's the initial design. And so, you know, when you're designing 2D, you get a really good interpretation of the 3 dimensions of the smile. But actually, really what you're doing is you're designing the front element. You know, again, you know, just to simplify the explanation is that, you know, the most important thing when we're designing smiles is, like when you're making a denture, is to start with the incisal edge position. So we're determining where in the face is the best place to place the incisal edges of the central incisors. And then from there, we work from a 2D to a 3D. So, you know, it's absolutely zero difference to how you would go through manufacturing a denture. You would place the central incisors, then determine, you know, the smile curve, the occlusal plane of the upper teeth, and then work in, if we want to get super excited, to the CR, opening the vertical and determining the rest of the denture, or the rest of the bite for that patient.
Okay, thank you very much, Dr. Bowers. I think we've covered most of our questions. Those questions that we have not responded to, I think you've shared your social media handles. I think the practitioners can get in touch with you on all those handles that you've shared with them. So I'm just going to hand over to Dr. Khan just to give his parting shot, and then Dr. Bowers, you can also give us your last words, and then we can close the evening. Dr. Khan Patel.
Yes. Once again, on behalf of SADA Limpopo, we'd like to thank Dr. Bowers for this very informative, inspirational webinar, and for always inspiring us to be better clinicians. And we'd also like to thank all the SADA members for attending tonight's webinar, and also SADA head office, Dr. Intabi Singh, Norma, and Madlis for making this evening possible. Thank you very much.
Thank you, Dr. Khan Patel. Dr. Bowers?
Thank you again for the opportunity, and I apologize for the little problem we had at the beginning. Technical problem in a digital lecture is not a good thing, but anyway, it happens. That's life. You know, that's life. And we recovered, and yeah, I managed to get through everything nicely, and I'll do my very best to look at wherever the questions are and try and answer them as well over the next day or two. So again, thank you so much, as I already said, to Limpopo branch, and to everyone in SADA who's really helped, honestly, and I really mean this, you know, all of us, to get us, you know, almost through this difficult, but the work that SADA have done has been amazing. And I think it's given us the confidence to kind of get back to our practices, and feel that there's someone or somebody, or there's always someone there to really navigate, as I say, these difficult times, and really SADA stood up and has been incredible. So thank you so much to the whole team. I can't single out one person, to be honest.
Thank you very much, Dr. Bowers, and thank you again to the Limpopo branch for choosing a very interesting topic. I think it will be very beneficial to a lot of our members going back into practice, those that are already back in practice. So I think we'll close it with Dr. Bowers' words, make it count. I think that concludes our evening. I think, let me just ask the panelists to just remain behind while our participants are logging out, and then Norma will end the meeting. Thank you. Dr. Bowers, I still owe you a phone call. What time should I call you tomorrow? I know you're a very busy man. What time should I call you?
Okay, you know what? To be honest, the best time, without, like, because I don't know what my schedule is tomorrow.